AFG team AFG 26-27 welcome you all for our first CME on endometriosis. On this auspicious day of Akshaya Tritiya, we start our tenure. So I welcome you all and hand over the mic to Dr. Ashwini, who is our MOC.
Thank you so much, sir. तर गुड मॉर्निंग. आज अक्षय तृतीया 3.5 मुहूर्तांपैकी एक मुहूर्त and our first CME of this first new turnover of Dr. Anurag Bhatte sir and a new team. So I welcome you all on behalf of AFG. I am Dr. Ashwini Kalyankar. तर खूप खूप अक्षय सुख लाभो, खूप खूप अक्षय धन लाभो, अक्षय प्रेम लाभो आणि अक्षय आरोग्य लाभो आणि इन ॲडिशन AFG कडून अक्षय academic activity लाभो. So let's start our first session. I'd like to request our chairpersons to come on the dais. Dr. S.N. Agarwal sir. Sir needs no introduction actually. He is the S.N. Agarwal sir. One of the senior most, more than 50 years of practice, medical director of Agarwal Nursing Home Bhayandar, and many awardees. Welcome sir. I request Dr. Seema Gadiwan madam. Madam is consultant gynecologist at Gadiwan Hospital, Malad, and past president and founder member of AFG. Welcome, madam. And Dr. Seema Rai, madam. She is also a senior consultant gynecologist and director at Navjeevan Nursing Home, and many awardee. Welcome, madam. And she is also a fitness influencer of Medicos. Over to you. Please invite our first speaker, Dr. Mukesh Gupta sir.
Good morning and a very happy Akshaya Tritiya to all of you. So to kickstart this session on endometriosis, which is such a big dilemma for all of us, and surgical management has always been, the center stage. But medical management, to whom it has to be given, how it should be optimized, and what are the appropriate patients for it, to navigate all these questions and to help us in our clinical practice, I welcome none other than Dr. Mukesh Gupta sir. He is wonderful orator. He is the president of so many associations in the past, AFG, AMC, Malad Medical Associations, and a big achiever. It is always a pleasure to listen to you, sir. Welcome.
Thank you very much. Thank you all of you. Wishing the new team and the team AFG, all members, a great year ahead. And I would first do a confession. I was not very keen to come today because I was actually traveling. And Anurag called up, he said, Mukesh, Akshaya Tritiya, first day, first lecture, I want you here, tujhe dena hi padega. And who can say no to Anurag, the Amitabh Bachchan? Here he comes. Can we have a round of applause for Anurag? So I think, ऐसी entry होती है ना अमिताभ बच्चन की. So looking forward for a great year ahead, Anurag. And the way he handled the first speech where he talked about the leadership and everything, I think we have a great year ahead. And coming after Nitin has done a great job. And I was sure that I have to be on time because the kind of chairpersons you have chosen in the morning are someone who are very respectful, at the same time always on time. और फिर मेरे बाद लेक्चर रख दिया तूने किसका? उस व्यक्ति का जिसको लेट नहीं किया जा सकता. So मुझे तो टाइम पे पहुंचना ही था, तो 10 में 5 कम को पहुंच गया था भाई. मतलब ये सोचो कि अक्षय तृतीया के दिन कैसे उसने अपने पत्ते सही खेल के सब चीज बनाया. First of all, I'm thankful to all of you for coming so early in the morning on a festival day and sparing your valuable time for this extremely important topic in the women's health care, and that is endometriosis. Anurag requested that before I start off with the algorithms about the medical management, I should say a few words about the etiopathogenesis, because if we don't talk about it, the session will not have a good flow. So I said fair enough. I am not wasting my time on the problem statement. We all know that most of the times that we come across these situations, the statement, problem statement is talking about millions of women who are suffering from this. And when we talk about millions of women, we are also talking about those millions of women suffering from chronic, debilitating pain and the trauma of not being able to have a child, and the psychological and emotional issues which causes them not to mingle with the routine life. And now that is the problem statement that we are dealing with. And this is the basis for my medical management journey. So we know that the two major problem is endometriosis and infertility. But I'm going to go one step ahead. And that one step ahead is also poor lifestyle. And that quality of life is also a very important part that we have to, because patient keeps coming back to us, because not just for pain or not just for the problem of infertility, but also lifestyle. So we have to address this. And if we have to address this, let's understand the pathophysiology first. Now, the possible mechanism for endometriosis, we all know that the endometrial cells coming from the menstrual fluid, स्टैंडर्ड लाइन जो अंदर लाइनिंग में होना चाहिए था आपके बाहर आ गया है पेट में, उसकी वजह से आपको तकलीफ है. हम सब ये लाइन कम से कम रोज दिन में एक बार तो बोलते ही है, हाँ या ना? Yes. So when we talk about it, let's talk about a little bit about pathophysiology. This leads to the adhesion invasion, and this cell growth leads to angiogenesis and anti-apoptosis, which leads to growth of these cells more than what we would have expected, and the neurovascularity going there. This in turn leads to release of a lot of stuff. I'll come to that, including the prostaglandin, which causes pain, and that leads to fibrosis and scarring pain. Now, if we look at this concept, the next thing that comes on our mind is that why is this pain? Now, pain has got three components. One is the nociception, another is actually what is happening at the cell level, and third is the combination of these two. So it is basically enhanced pelvic nociception, which is one of the major immune response because of which the central sensitization happened. Now, three things are happening at three different places. One at the peritoneal level. Now, why is it important? ये बकवास क्यों कर रहे हैं हम फर्स्ट या सेकंड ईयर का? इसलिए कर रहे हैं क्योंकि if we understand these concepts, we will choose the medical line depending on individual case scenarios and decide what is best for that patient. Now, when we talk about peritoneal fluid, there is peritoneal inflammation, and this in turn is actually affecting the scarring, pain, everything. But what are the agents there? The reactive oxygen species, PGE2, acidosis, iron, all these things are working here. Another thing that is happening at the endometrial lesion side, the abnormal endometrial cells, there is again increased cytokines, there is increased growth factors, neutrophils and chemokines, which again leads to inflammation at the site of lesion. The third thing is the pain being sent through the peripheral nerve. Here we talked about the central enhanced pelvic nociception, and here we are talking about the local peripheral nerve ending, which is regulated by the PGE2, tumor necrosis factor, NGF, etc. And it interleukins, which leads to this. So now if we want to plan the medical management, we have not only to work on the endometrial cells, but also on these inflammatory markers, which in turn will also lead to central sensitization, which here is a very great important aspect when it comes to lifestyle. So the pelvic pain may be because of so many more things, not just endometriosis. हम endometriosis पे नहीं stick हो सकते हैं. So हमें differential diagnosis सोचना है, और accordingly we have to plan the medical management. Now let me take a little 2 minutes on this concept of why it is important to have a chronic long-term treatment plan, a strategy for life and not just for a few years. Let's understand this woman, a girl who comes with endometriosis. It may be as early as at the beginning of her early years of her menstrual cycle, and it may luckily get over when she starts her prolonged obstetric career with multiple breaks in the hormone supply, or unfortunately it may extend beyond that, and sometimes it may continue till just before menopause. Now, there are most of the patients who will go through this journey for good 1 or 2 decades of life. Whatever you do, the intervention is not going to be a horizontal impact, it has to have a longitudinal impact. You cannot just give a treatment which is going to help her for that particular moment for some time. It has to have a plan for a very long term, and that is what is going to change the dynamics of the treatment plan. So when we're talking about, when we talk about these journey of pain cycles, so one, we all know that there is a lot of factors which affects the mood. Like I can't say no to going out. If I go out, it is going to cause more pain. That in turn will lead to a bad mood, and that can have an impact on the life. अगेन रिलेशनशिप आर अफेक्टेड बिकॉज ऑफ दैट. सब दोस्त लोग जा रहे हैं और मैं ही नहीं जा पा रही और मैं जाती हूँ तो मेरा पेन होता है, तो सब बोलते क्या नाटक कर रही है, बिकॉज मोस्ट ऑफ देम विल नॉट अंडरस्टैंड. इट अफेक्ट्स द स्लीप साइकिल एंड इट्स इम्पैक्ट बिकॉज ऑफ दैट, वेदर इट इज द मूड or whether it is because of general health or PCO or even a matter of fact her quality of life. So it is important to look into the diagnosis. Now when we talk about diagnosis, I'm going to say a couple of words here. There was a time when the diagnosis was purely dependent on the visibility of the lesions on scopy or laparotomy before scopy. Now the guidelines say that you do not have to rely on visual confirmation by surgical approach. An assumption of endometriosis in a girl who deserves treatment is good enough to start medical management. This is a very great take-home message I'm giving you. You do not need to put in a scope to confirm endometriosis. ESHRE guidelines now 2022 says you can start the medication even without putting in the scope. And even if there is no demonstrable USG lesions, even if the woman is just complaining of pain and which you are sure because of your clinical smartness, you can start with medical management. And that is what we are talking about. So we all know that sonography is the gold standard and CA125 is just suggestive. MRI and laparoscopy are definitive diagnosis, but you do not need an MRI and laparoscopy to come to the plan of action. Now let me just give you one algorithm which I had come across from FOXY guidelines. This is FOXY guidelines. This is coming from FOXY 2019 guidelines. It says that empiric GnRH agonist cannot be started early. You have to understand that first have a diagnosis, start with Dinoges and NSAIDs, and then you use the medication. If it doesn't work, then you go for scopy. And then so on. So आप अगर देखेंगे तो यहाँ मेडिकल मैनेजमेंट आ रहा है, यहाँ मेडिकल मैनेजमेंट आ रहा है. स्कोपी होने के बाद अगेन इफ वी आर गोइंग थ्रू दैट, अगेन देयर इज अ मेडिकल मैनेजमेंट कमिंग इन प्ले, एंड देन इफ देयर इज रिलीफ देन अगेन कंटिन्यू. सो मेडिकल मैनेजमेंट इज समथिंग विच यू नीड टू अंडरस्टैंड. दीज आर वेरी गुड 2 documents. I would request all of you, whenever you are in the mood to read more about endometriosis, these 2 documents are very useful and we should be focusing on this FOXY focus and endometriosis guidelines. Now there are some initial treatment approach which they have talked about, and if you look at a visual summary, the symptoms and signs helps. This is a very busy slide, but what I want to tell you here is that if we don't look at this busy slide and if we try to understand the basic gist of it, it is that we need to assess the needs. Whatever is the symptom sign investigation, you assess the needs, the circumstances, the symptoms, the daily living, physical needs, psychosocial needs, psychosexual needs, priorities, work study. Of course, you need to also look at the cultural background. OC pills may be a gold standard, but the mother says, नहीं, मेरी बेटी को बच्चा बंद होने की गोली आप कैसे लिख सकते हैं? अब उसका तो कोई आंसर ही नहीं है. So we have to understand those aspects also, and then of course the emotional needs of what are the various aspects for her. It may be as simple as desire to have the menses. नहीं मुझे menses तो चाहिए डॉक्टर. अब यार तेरी प्रॉब्लम स्टेटमेंट वहीं से शुरू हो रही है. नहीं मुझे menses तो चाहिए डॉक्टर. Now you have to sometimes consider that and then look at that. Of course, we have to decide what is the cause and what is the outcome. So analgesics for pain, hormonal treatment for pain, but if it is fertility, we cannot use that, because if fertility is priority, then something else has to be done. So if there is pain, you go on this side. If it is fertility, you go on this side. Now this is the basic overview which decides. Now what does the SOGC guidelines say? Again, it says the same thing. Suspected endometriosis, start with COC and continuous or cyclic manner. And if it is not working, if there is a failure, then go to laparoscopy. And if this fails, or even if you have done it, you may require medical therapy again. So here again, we are talking about medical therapy at 2 phases. One, before the surgery is chosen. Second, after the surgery is chosen. Okay. What about pain? For ESHRE guidelines 22 says that if there is a pain, this is direct pick of the graph or the lay from the ESHRE guidelines. And it says that if there is pain, the different options should be used by shared decision making. Now I'm going to take a pause here. Shared decision making. It's a very important component of ethical management in modern healthcare, because they have access to the same information that you have. आपके साथ में जब वेटिंग एरिया में हम उन्हें 1 घंटा बैठाते हैं, आधी घंटा बैठाते हैं, और सर के पास तो शायद 2-2, 3-3 घंटे बैठते होंगे, ठीक है. और बैठने के बाद जब अंदर आते हैं, जब तक उन्हें चैट जीपीटी, जेमिनी, क्लॉड सब कर लिया होता है, और फिर अंदर आके सिर्फ चेक करते हैं कि आप वही बोल रहे हो कि जो उसमें लिखा है कि कुछ अलग बोल रहे हो, एंड दे आर कंपेयरिंग. एम आई राइट और नॉट? Are you seeing? And we all are also doing the same thing now. So you have to understand that you have to have shared decision making. You need to give them those options which they already know now, and tell them that why I have chosen that. Gone are the days when there was a patriarchal approach. कह दिया ना, बोल दिया ना, वो गया वो वाला जमाना. कौन सी पिक्चर थी वो अमिताभ बच्चन वाली? कभी कशी कभी हम, अभी वैसा नहीं चलता है. अगर वो किया तो कम ही गम है हमारी लाइफ में, मेडिकल करियर में. यू कैन नॉट फोर्स, सो नो पेट्रियार्कल. नाउ दिस इज कॉल्ड एज डायरेक्टिव काउंसलिंग. There is no such thing as non-directive counseling. So we need to have a shared decision making and then choose for pain the first line, of course, the NSAIDs, then the hormone, and if required, surgery as a final option. You have to look at individual preferences, side effects, cost efficacy, and other management, and then choose. What about infertility? Here again, the terminology shared decision making comes into play again. Then here we are strictly saying no hormonal treatment for obvious reasons. Ovulation ही नहीं होगा तो बच्चा कैसे होएगा? So obviously here we have to talk about surgery and medical. Now, do we need a surgery or we directly go for that? We'll talk about it a little while from now. But we have to understand that hormonal treatment is not advised here. Delaying, I'm going to see this again and again, okay? But I'm saying it right now for the first time in this talk. Delaying of the surgical intervention by medical management to control the endometriosis, to enhance the outcome of your fertility treatment is not recommended. Have you understood what I've said? भाई मेडिसिन पहले चालू करके थोड़े टाइम तक आपको रेडी करते हैं, फिर अपन चालू करेंगे इनफर्टिलिटी ट्रीटमेंट. इज नॉट अ स्ट्रॉन्ग रिकमेंडेशन. एशरे 2022 if I'm not mistaken. So that leads to the further plan of treatment. Now let's understand the medical options that we have. This is our armamentarium. When we talk about the armamentarium, we have combined contraceptive pills, which is gold standard, and progestogens, which are the first line. So these two are the first line. Okay, here we can talk about. Now there are progestins which can be used, like Dynogest can be used for a very very long time. There is data which is talking about थोड़े टाइम की बात है, then they will say decade of data, but right now it is some 7-8 years data. And then उसके बाद में other options which are, I'm sure many of you have got the patients on Dynogest or similar medical treatment for years. Personally, I have been using for more than 2 years. How many of you have tried it on patients for more than 2 years? So many of us. Right? So many of us. So it does work. So we have to understand that before jumping to the newer molecules, which are also very amazing, and we are going to hear a lot about the pros and cons and the fine tuning about it from Dr. Saragi sir, and I'm sure all of us are waiting for that. But before we jump to the second line, do not underestimate the power of the first line treatment. So exercise your right to choose something which is simpler and more acceptable and easier to manage. And then comes the second line treatment, the agonist and the antagonist. Of course, there are some options and discussions about the pain relief and the refractory nature of the disease being helped by so many more options like aromatase inhibitors. But, we have to go to them not as a primary line. We have to go to them later on. So, GnRH agonist, so I'm not getting into the detail of the various different drugs today, because that is not the scope of discussion today. The scope of discussion is more about the clinical strategies that we use when we are going to face endometriosis. So we understand now that it is inflammatory. We understand now that it is dependent on estrogen. ला मार्कर दे दे भाई, ये PDF में है, मार्कर. हाँ. So we understand now that it is estrogen dependent or inflammatory. And we understand that everything which is there outside may not behave the same way, but it has a common area where different types of things are happening. And when we are talking about different locations, there is one very interesting thing that happens, that, let me see if I have my chat GPT. I had opened the chat GPT also. Here. This is very interesting. So I have tried to, oh God. Okay, for some reason this is not opening. Yeah. I went to chat GPT and I asked this interesting question. Okay. The question was this: can you make a checklist to be presented to medical professionals on criteria of medical versus surgical interventions? And following the situations that we, so let us understand that I wanted to divide into 3 phenotypes. The 3 phenotypes are ovarian endometriosis, superficial and deep. मैं ये क्यों कर रहा हूँ ऐसा? Because see, give a man a fish in his diet, he'll not be hungry for a day. Teach him fishing, they'll never be hungry ever. So I'm doing this experiment so that you understand that how AI can be used for your day-to-day practice. And this is one very interesting example for it. And then I asked them about the 3 different checklists: ovarian endometriosis, superficial peritoneal, and deep infiltrating. These are 3 phenotypes that we see commonly in our practice. Okay. Also, we do a segmentation, adolescents, women's. भाई ऐसा मत कर, ऐसा मत कर. नहीं ठीक है. अच्छा मेरा टैब बंद हुआ. ओके सॉरी. वो ऑटो मोड में, वो एनर्जी सेविंग के चक्कर में, हाँ एनर्जी सेविंग के चक्कर में. Now, I also said that I wanted to segregate these discussions into adolescent with endometriosis, a young girl, woman. मेरे को कल अनुराग ने बोला मुकेश हर segment का घर पे जब जाए ना हमारे सारे delegates, they should know when to do the surgery and when they are doing the surgery they should do the right surgery. और उसने बोला कि सबको बोलना कि मुझे बुलाया surgery के लिए, ठीक है? So that is another interesting thing, that how do we decide on that? Okay, so let's quickly run through. So 3-4 situation: adolescent, women seeking fertility, middle age not desiring fertility, and see the interesting division that is. Step 1, define the phenotype, whether it is ovarian, superficial or deep infiltrating, and how we have talked about. If there is ovarian endometriosis, that is size of more than 4 or 5, then we can talk about intervention which is necessary. Otherwise, we have to see whether the size is big or not, whether the pain was there or it's an incidental finding, what is the ovarian reserve, and what is the suspicion of malignancy. For superficial endometriosis, again the same thing. Now, the next step was the core decision filter, where you have to apply for every patient. That is severity of pain, fertility desire, reserve kitna hai, prior surgeries hua hai ya nahi. So, all of us have seen patients with more than 2 surgeries for endometriosis. Yes or no? ऐसा कोई गायनेक नहीं होगा जिसने देखा नहीं कि 2 से ज्यादा सर्जरी एंडोमेट्रियोसिस की हुई है. ऑल एंड जो मेडिकल कॉलेज में तो 4-4, 5-5 देख के बैठे होंगे, right? So I think this is something which we have to understand, that it is not going to stop here. So we have to ask them how many surgery and what was the status of recurrence after that, what is the imaging finding, and then uske baad mein what is the patient preference and shared decision making. Now for ovarian endometrioma, cyst less than 5 or 4, you can think of medicine. Minimal or moderate pain. For severe pain, you may go for surgery. Low AMH, I would say goes one step. Severe pain or pain not relieved by analgesics and medical management. Only then you go for surgery. If there is a rapid growth, yes, we have to do. And if you are doing IVF cases, again, ASHRAE says, do not operate on endometriosis, but be smart enough not to puncture the endometriosis while home pickup. Am I right? IVF consultants, anyone? Would you agree? Yeah, so this is something which has come to light, that surgery is not a mandatory thing before IVF pickup also. Then comes superficial peritoneal. Now here there is a challenge. Here the diagnosis is not on the radio imaging, but it is on clinical suspicion. And then you may start, and again I am saying, there is recommendation to use second line, that is GnRH analogs, even if you are sure of the endometriosis diagnosis and there is no large lesions for superficial peritoneal, because if you don't do that, you are going to leave scarring and distorted anatomy, which is going to affect the fertility. Deep infiltrating, again, one more thing that you need to understand about here is that surgery is needed only if there is a refractory pain. It is not that deep infiltrating to karna hi padega. But if there is bowel obstruction or hydronephrosis, then of course you need to tackle it. But again, there you have to remember that you need to follow it with medical management. I had this young girl, sister of a doctor, who got a surgery done. Twin sisters, एक बहन, दोनों का endometriosis. एक बहन ने surgery कराया, एक ने नहीं कराया. Classic. That was my eye-opening journey in my, twin sisters. One got surgery done because of hydroureter starting to develop. Another did not get it done. And then she did develop hydroureter after some time. And then she said, मुझे तो surgery नहीं कराना है क्योंकि मेरी बहन का कराया था और बहन का करने के बाद फिर से आ गया. तो मैं तो नहीं कराने वाली हूँ, आपको जो करना है कर लो. So then we went on with GnRH analogs, and at that time antagonist was not launched. But it did work for her, and she has been without surgery for almost now 6 years. Unfortunately, because she's not got married. मैंने सोचा तो शादी करेगी तो अपन ऑपरेट करके बच्चा प्लान कर लेंगे, but it did not work for her. I cannot now change the energy saving mode. I'll do it afterwards. Okay, so now the case-based checklist. Again, adolescent, start with pills. So we know that COC is not first. We have to start with progestins. आप मेरे बच्चे को बच्चा बंद होने की गोली दे रहे हो? नहीं, हम सिर्फ प्रोजेस्टेरॉन दे रहे हैं. आपके बच्चे के शरीर में जो हमेशा बनता है वही दवाई दे रहे हैं. खाली कोशिश ये कर रहे हैं कि जो एस्ट्रोजन ज्यादा बन रहा है उसको कंपेंसेट करने के लिए थोड़ा प्रोजेस्टेरॉन ज्यादा देके बैलेंस कर रहे हैं. ऐसा कुछ बोलने से थोड़ा सा कन्विंसिंग ईजी हो जाता है. आई एम यूजिंग दोस काउंसलिंग टूल्स एंड शेयरिंग विथ यू व्हाट आई हैव बीन ट्राइंग टू डू ओवर द इयर्स. What about women seeking fertility? You have to understand that contraception cannot be used, and it is again case based. If you think that your outcome is possible without the surgery, then please go ahead and start the treatment. Especially IUI, you don't need to do surgery for IUI unless you know that there is definitely anatomical distortion. Before IVF, avoid routine surgery, proceed to IVF directly. But if hydrosalping, severe pain or technical difficulty, yes, there is a rule, and this is not me, it is ASHRAE. So now I am going to see this very interesting photograph. Okay, Now this is a lovely, a photograph which I used AI to produce it. So it is copyright आज ही सुबह बना है, तो इसके लिए आपको कहीं नहीं मिलेगा. Identify the phenotype, ovarian and endometrioma, superficial or deep. Core assessment, pain, fertility, reserve and imaging findings. Depending on that phenotype, then choose medical or surgical. If it is small, minimal pain and pre-IVF and you're waiting कि अभी नहीं अभी रुक जाओ थोड़े दिन बात करेंगे IVF, then medical is the gold standard. If it is large, then you have to go for surgical option. If it is not being relieved by the medical, then go for it. Superficial peritoneal, medical first line. Again, you have to understand that hormone therapy and wait and watch may work because there is no other, but there is a refractory pain which is affecting the lifestyle. Only then you think of going in to see what it is there, what is inside. Now, I'm going to make another important statement. The pain and the visual appearance of the lesion are not correlating. Sometimes a girl may complain of lot of pain और अंदर कुछ नहीं दिखता है, और sometimes अंदर बहुत कुछ निकलता है लेकिन बोलते मुझे तो कोई पेन है ही नहीं, मेरे को तो कभी पेन हुआ ही नहीं. So you have to understand this statement again. The pain and the visual appearance of the lesion on laparoscopy do not correlate well. Okay, means it is not a definitive short thing. Medical management for deep infiltrating, if it is mild symptoms and no obstruction, by all means use medical management. Don't jump to surgery just because this is infiltrating, because the medical may reduce the inflammation, may reduce the lesion and it may help. Surgery is definitely a preferred option. The final step in algorithm, if pain is dominant, medicine. If fertility is the goal and if it is manageable, don't do that. But if it is not manageable, go for surgery. And that is the final algorithm which I can suggest from you from this AI journey that I did. Now I am going to give a few more approach to this. The when and how of the approach. So see, मैं क्या कर रहा हूँ, एक ही situation को अलग-अलग angle से attack कर रहा हूँ. So that आपके दिमाग में जब clinical algorithm run करेगा subconscious mind में, when your subconscious mind which takes the reflex decision of doing surgery management, it goes to your prefrontal cortex and start analyzing these pathways कि कैसे करना है. Now what is this when and how of approach? So when we talk about when and how approach, if it is adolescence, first line is to protect pelvic anatomy and protect it from early scarring and damage, and also the symptom control. Third thing is you have to have a good ovarian reserve for these young girls in adolescence so that they do not land up with poor AMH when we are passing them for the therapy. Lastly, even if you do land up with surgery, you will have to give medical approach. Now how? We have already discussed. First line for pain is NSAID, then combined pills and progestogens. Second line is what Dr. Saragi is going to talk about, antagonist, and of course the agonist is also an option. Adjuvants. Now there is a huge role for these adjuvants. Why it is there for the huge role? Because the inflammation, the prostaglandins, the reactive oxygen species are working at the cellular level. So we can also use them. So it may not be the treatment, but it is also an adjuvant to our treatment. And that adjuvant is very useful. So Mukesh, do you prescribe any antioxidant? Yes, every patient of endometriosis, I prescribe antioxidants. There's nothing to lose, but only to gain. So I am using this as a very, very useful option to give. What about management? Again, pain versus fertility is going to, as I showed in the algorithms. Now this is an interesting chart because all of us are using this left, right and center and we are very happy with it. I'm going to say that whomsoever I have used, I'm not unhappy with the use of these drugs. But you need to understand that still there is a role for progestogens. So for suppression, if it is moderate, it works better. If it is profound, this works better. Symptoms, mild to moderate, this works better. Highly effective if this has not worked and we have moved on. Bone health, obviously lesser impact as compared to this. Vasomotor, again, same thing, rare as compared to this. But we do have progesterone hot flashes also. Then mood impact, high correlation. Higher correlation to depression because of the progestogenic fog. You know that terminology, progestogenic fog. But here again, you have to understand that because of the vasomotor symptoms, it can also have the impact on the mood. Metabolic shift, possible weight gain and change in the lipid profile if you don't use the right combination of OC pills. But here, this is generally weight neutral, which is an advantage. Also, there is a huge advantage of cholesterol control, which is also there with this newer antagonists. Cost, let's not talk about it. So because that is not something we don't know about. So pain management and infertility, these are the various tools which we use. This is a very nice summary slide where our main strategy here is to achieve amenorrhea. Our main strategy is to restore or maintain ovulation. And depending on that, we choose what we have to go about. And I think if we go to when to avoid surgery slide, Asymptomatic endometriosis do not need surgery. Just because you've seen something, that doesn't mean that we have to operate. You have to cut this down. Accidental finding in endometriosis without pain or infertility do not require intervention because you're going to damage. So we started from ablative surgery to resection and removing of the cyst and just peeling it off. But even that can cause trauma to the ovary unless it is necessary. Okay, ovarian reserve concerns, women with low AMH, conservative management of endometriosis is preferred over that. So we also have to end up the whole session by a word on the non-pharmacological intervention. Actually, if you go on internet, सारे के सारे Insta pages, सारे के सारे various different reels are talking about anti-inflammatory because there are more number of nutritionists for every one gynecologist, and all of them want business. So they say कि हमारे पास endometriosis का एकदम targeted diet plan है. आप हमारे पास आओ और ये डॉक्टर लोग की दवाई की जरूरत ही नहीं है, आपका एंडोमेट्रोसिस ठीक हो जाएगा. ठीक है. Now that because they are not governed by Maharashtra Medical Council or national. Just for the record, please vote all of you for the Maharashtra Medical Council election. Do not miss out on your right. मैंने बोल दिया. ठीक है. Okay. AMC, AFG सब तरफ से हमारे को बोलना पड़ता है. Okay. Non-pharmacological intervention, lifestyle. It is an amazing intervention, not just for the anti-inflammatory role for it, but also for scarring in the pain, but also for mood elevation and improving the quality of life. So psychology, the CBT really works. Trust me, for most of my patients who are for long-term therapy, this is a single aspect which helps me to keep them hooked up to me for years together. नहीं तो एक बार दो बार आएंगे बोले बकवास डॉक्टर है, मैं जा रहा हूँ सरावगी सर के पास. ठीक है. So if you don't want that to happen, you have to see to it that you address their psychological needs because they are needing someone who you are going to need them for the. I think I've wrapped up the session and I'm going to end up the session by saying that if at all you need surgery, you remember that surgery is not a definitive option because uske baad bhi, because of the pathophysiology, it's going to come again. So you need to be prepared with your medical whole journey. Second thing, if the surgery is needed, there are two types of surgery, conservative and definitive. For fertility enhancing, you do not need definitive. For non-fertility, post-fertility, definitive is the solution unless you don't want to give her early menopause. But last line, if the surgery is done, it should be done by the best hands. We cannot explore or dabble or try to experiment with the surgical approach. Now, with this era of special trained pelvic endometriotic dedicated surgeons, it will be really not nice on us to experiment with our scope and instrument. चलना खींच के निकाल के साफ करते हैं, cauterize करते हैं, bleeding हो जाएगा तो. That's not. Removing of lesions from peritoneum by burning versus excision versus peritonectomy is definitely a decision which has to happen on table. And the best minds and the best hands can do it. You have the best mind. Do you have the best hand? It is for you to decide. You may have a very great hand. You please go ahead and do it. If not, we have access to better people. So I'm going to summarize one thing. Endometriosis management is a strategy for life. It is not a horizontal intervention. You will have to use multiple drugs at different stages of life in the different dosages and in different time duration. The moment we get some data which says that this particular drug can be used for long number of years without complication, it gives a great elation in the mind. Thank you very much for your patient hearing. I was wanting to show one more aspect on this, and that was up to date. These apps like Up to Date, they have what was the last thing which I was trying to show. They have extremely beautiful algorithms for learning and taking it home back. So these are the tools that you can use when you are in that fine-tuning decision making. See, this what I have talked about is a broad overview, but every patient is different and you will have to choose as per that. Thank you.
Thank you, Dr. Mukesh Gupta, for such an elaborate talk. Really informative. Now I would like to call upon Dr. R.M. Saravgi sir on the dais to give a talk on elagolix. Sir is a question maybe after sirs. That's okay. Sir. Questions will take together after the second talk. Sir is an emeritus professor and HOD at Dr. R.N. Cooper Hospital and St. G.S. Medical College. Currently, he is a director of Saravki Group of Hospital. He is a senior consultant at Nanavati Hospital. And I think sir is a teacher of teachers. He doesn't need much of an introduction. Over to you, sir.
Good morning, everybody. I think we had a wonderful talk by Dr. Mukesh Gupta, and I think he has made my life very easy. Only thing I want to point out is whatever he has mentioned about FOXY guidelines, they are of 2019. That's an outdated guideline. It requires to be refreshed, and probably we may find new guidelines coming out with new drugs which are there on the horizon for us to understand which is good for the patient. Friends, my talk is on Elagolix strike a balance of efficacy and safety. This is a new drug which has come in the horizon. We all know about endometriosis. It's a disease in which tissue similar to the lining of the uterus grows outside the uterus, which Mukesh rightly pointed out. The implants grow and invade tissue in their vicinity, causing inflammatory reaction, resulting into chronic inflammatory disease, chronic painful condition, negatively affected quality of life. I'll tell you my own story. I started doing laparoscopy way back in 1975. Maybe I was the first person at Nair Hospital who started laparoscopy. And my topic was infertility, laparoscopy in cases of infertility. I did 100 cases of laparoscopy in 1995 to 1977. In 2 years I did 100 cases, and what did I find? We used to find blisters on the top of uterine surface. Now our focus was basically on infertility, nothing else. We never thought about endometriosis in those days. Invariably we used to think that this may be tuberculosis, and we used to put the patient on anti-TB treatment. So you can imagine how the things have changed. When I was an undergraduate student in 1970, endometriosis was never taught to us. It was called as a disease of thesis. You are not supposed to be reading because it doesn't exist in India. It's a disease of Western world. And now probably you will be shocked to know the incidence of endometriosis in India is almost 22% of all the ladies, mind you, are suffering from endometriosis. That is the situation today. If you look at this, the world population has 190 million of reproductive age women and girls globally suffering from endometriosis, out of which 42 million girls and women of reproductive age are affected in India. That is the situation today. This is very important slide. If you look at this, you have estrogen receptor, alpha receptor, estrogen receptor, beta receptor. They are generally present in endometrial cavity. Alpha receptor is basically meant for hyperplasia of the endometrium. So it's present in good quantity as far as a lady is concerned, while beta receptor is present in less quantity in a normal person. But in an endometriosis, what happens? Alpha receptor becomes same, but beta receptor increases in size. The number of beta receptors are much more in a case of endometriosis. And what does it do? It causes estrogen dominance, that means cell proliferation, inflammation, angiogenesis, non-receptive endometrium, unopposed endometriotic lesion growth, pelvic pain. This is generally present in endometriotic lesion which is present in the body. Nowadays we have gone one step ahead. Whenever we are doing a surgery in a case of endometriosis, we send the material to find out endometrial receptor beta. If it is more, patient is likely to get the recurrence of the disease. If it is less, then probably patient may not get the recurrence. And that is how probably a stage will come when we will be able to identify and tell the patient that you are likely to get the recurrence or you are not likely to get the recurrence. Basically it causes progesterone resistance and all the problems start after that. We all know about pathogenesis of endometriosis. It causes increased estradiol, increased inflammation, decreased progesterone. Let us look at SF1 receptor, the local hormone driver in endometriosis. Steroidogenic factor 1, SF1 and nuclear receptor NRSAI1 that regulates genes involved in steroid hormonal biosynthesis. Endometriotic lesions, SF1 becomes abnormally upregulated due to epigenetic changes. It is 12,000 times higher expression than normal tissue. Drives local estrogen production within the ectopic lesion itself, mind you, independent of ovarian estrogen. SF1 drive pathway stimulates expression of aromatase, converts androgen to estrogens locally, enhances cholesterol transport into mitochondria for steroid synthesis. Basically, it results into self-sustaining estrogen prostaglandin inflammatory loop that maintains chronic pelvic pain even with systemic estrogen levels are moderate. Management, as rightly mentioned by Mukesh, it can be non-hormonal, hormonal, it can be NSAIDs, it can be anti-angiogenic factors like cabergoline. It can be hormonal in the form of GnRH agonists, progestins, dinogests, levonorgestrel IUDs, OC pills, GnRH antagonists, aromatase inhibitors. What is the ideal solution? Partially suppress estrogen enough to treat symptoms while maintaining sufficient levels to prevent hypoestrogenic effect. If you suppress it too much, it will result into bone osteoporosis. Let us talk about elagolix, India's first oral GnRH antagonist. What are the benefits? GnRH antagonist binds competitively to the GnRH receptor in the pituitary gland and blocks endogenous GnRH signaling. That means directly it acts on the pituitary. As a result, there is rapid suppression of LH and FSH. Gonadotropin suppression leads to dose-dependent decrease in serum estradiol concentration, and hypoestrogenic states simultaneously manages the endometric lesion, resulting in pain relief. It is basically an oral GnRH antagonist. The advantage is its oral administration, rapid absorption, T1 by 2 is 2.4 to 6.3, metabolized mainly in liver and 90% excreted in feces. How does it work? If you look at this slide, dose-dependent suppression of LH and FSH levels lead to decreased levels of estradiol and progesterone. The decrease in LH FSH level is readily reversible upon discontinuation of elagolix. That is what you want basically. It should not happen that it becomes a permanent factor, it should be dose dependent, and minute you stop the drug it should reverse. Suppression of LH and FSH levels start at 4 to 6 hours after administration of a single dose. That means you can imagine how quickly acting the drug is. and subsequent suppression of estradiol levels occurred by approximately 24 hours. If you look at this, when you start with 150 milligram, the estradiol level maintained is 44 pg/ml. When you start with 200, it comes to 14 pg/ml. Again, we will discuss about it a little later. Now, we have various options available. We have Dinoges, which have been using all these days, Dinoges plus ethynyl estradiol, leuprolide, elagolix. This is the only drug which is available in two combinations, 150 milligram, 200 milligram BD, and in fact, last year we had a meeting on behalf of Oxy in Pune, and it was decided to do experimentation with 200 milligram OD. Instead of 200 milligram BD, we started using 200 milligram OD, and I have already got 7 patients on 200 milligram OD. It allows flexible dosing regimen based on severity of the symptoms, which is not the case with other drugs. Why elagolix monotherapy is sufficient for management of endometriosis? If you look at this, the basis of estrogen threshold hypothesis is formulated by Barberry et al. A concentration of estradiol that may not stimulate endometrial growth and partially prevent bone loss is a concentration of estradiol between 30 and 45 picogram. If you achieve this, probably you have achieved everything in life. And mind you, what happens with 45 pg/ml? The bone loss is practically nil. That is the beauty. It was demonstrated that with E2 level of more than 10 milligram picogram per ml had a sufficiently higher BMD at the lumbar spine, the proximal femur and the total skeleton. In the study of osteoporotic fracture, it was found that endogenous estradiol level of less than 5 picogram was associated with more fracture level. So, you have to take into consideration of this also. See, we try and forget one thing, that generally we come across a lady who is around 30, beyond 30, who leads treatment. In that case, already osteoporosis factor may be there. So, low dose elagolix 150 milligram OD maintains serum E2 level at 42 picogram per ml. This is the best thing which can occur with 150 milligram. Ideal for mild to moderate pain associated with endometriosis causing dysmenorrhea, non-menstrual pelvic pain, offers significant and quick relief in endometriosis pain, minimal BMD loss concern, maintains menstrual cyclicity in the majority of the patient, incidence of hot flushes similar to Dinoges can be given for a long time, that means up to 2 years, and does not require any head-back therapy. Similarly, when you give 200 milligram BD, it causes near and complete strong suppression of E2 level that can drop down to 12 picogram per ml. Mind you, when you use 200 milligram BD, the level drops down to below 12 picogram, that means you have to add calcium and other factors. It is useful for severe dysmenorrhea, severe non-menstrual pelvic pain, dyspareunia, dye, etc., etc. So, you have to add back therapy. Now, look at the disease response to various concentration of estrogen. When the estrogen levels are about less than 20, it is useful in treatment of fibroid. But when the levels are less than more than 40, it helps in regression of endometriosis. So, basically this is a drug of choice for endometriosis. It maintains regular menstrual cycle in 80% of the women on treatment. So, even a lady feels happy that I am getting my periods regularly. The studies have shown when you use 150 milligram and 200 milligram, maintenance of menstrual cycle is 83% when you use 150, while it is 48% when you use 200. Amenorrhea occurs in 6 to 17%, 13 to 52%. Resumption of menses when you stop. Within first month of treatment, 77% resume menses, while in 200 milligram 55%, second month of treatment 95%, 91%, 6 months of treatment 98%, 96%. Mind you, what happens to ovulation? Ovulation rate is 50% when you use 150 milligram OD. So patient can conceive, and mind you, studies have been done as far as conception is concerned, and they have not found any ill effect on the newborn baby. So what are the advantages? Oral delivery, rapid onset, rapid reversibility, immediate gonadotrophin suppression, no flare effect, dose dependent partial or full estrogen suppression, and dosing flexibility. It was approved by US FDA in 2018, Canada 2018, Israel 2021, and India 2024. Now let's look at landmark trials ILARIS 1 and ILARIS 2. ILARIS 1 trial was conducted in USA and Canada, while ILARIS 2 trial was conducted in rest of the other countries. Now we have ILARIS 3 and ILARIS 4 trial also. ILARIS 3 and ILARIS 4 trials were further continued up to 12 months. So when ILARIS 1 trial was conducted in USA and Canada, they continued giving the medicine for 12 months. Then it becomes ILARIS 1 plus 3. When they continued in ILARIS 2 trial, it became ILARIS 2 plus 4. And what did they find? Reduction in dysmenorrhea with elagolix. They found that both are equally effective. What happens to reduction in non-menstrual pelvic pain with elagolix? Mind you, we have been bothered only about pain due to endometriosis. But we forget that sometimes there can be pain which may be associated with endometriosis as well as due to other factors. And what did they find? They find good relief even with this. So higher doses of elagolix led to fewer rescue analgesic uses or placebo. At 6 months, significantly more women on either dose of elagolix reported much or very much improvement versus placebo, and elagolix improved quality of life compared with placebo at both 3 and 6 months. Now this is about what I told you just now in dyspareunia. What they have found in study is in dyspareunia cases or in cases of dye, basically you should start with 200 milligram BD for 6 months. That is what they have advocated in these cases, and they have found good results as far as these things are concerned. You can skip these things. As I told you, 150 milligram OD, more than 80% of women had no change increase in BMD or less than 3% decrease. 200 milligram BD, more than 40% of women had no change increase in BMD or less than 3% decrease. What is more important, after treatment cessation in ILARIS EM4, BMD values returned towards baseline values during the post-treatment follow-up period. That is the most important thing as far as this drug is concerned. Impact of elagolix on opioid usage. If you look at this slide, they received 150 milligram and 200 milligram. Reduction in average pill count. Elagolix provided sustained efficacy over 12 months, suggesting treatment with elagolix can be effectively prolonged in appropriately selected patients with symptomatic endometriosis. Similarly, the quality of life improves whenever you have given this drug. How fast is the pain relief with elagolix monotherapy compared to relagolix with add-back therapy? What did they find? They found that immediate relief is there significant and rapid reduction in pain score with elagolix 150 mg and 200 mg within 4 weeks, while this took almost 8 weeks for the pain relief. Now, this was a trial conducted on Indian women. And what did they find? It was a phase 3 randomized multicentric double blind double dummy parallel group active controlled comparative non-inferiority study which was conducted on Indian people. Treatment period was 24 weeks. What did they find? Now, this is a comparison between elagolix and Dynogest tablet. Demographic and baseline parameters were compared in both arms and no significant difference between test and comparator product. That means what did they find? That there is basically no difference between use of Dynogest and this drug. The change in BMD score for baseline to days 169 shows no significant reduction in both tests and compared arms. The BMD scores are comparable between the treatment arms at visit 1 and visit 7. That means when you use elagolix or you use Dynogest, there is no difference at all. Study conclusion: elagolix tablet 150 mg OD is non-inferior to Dynogest tablet 2 mg OD in treating moderate to severe pain associated with endometriosis in terms of reduction of pain. As the upper bound, the reduction of DY score and NMPP score from baseline to day 85 and day 169 were comparable between elagolix 150 mg and Dynogest 2 mg. The basic problem which occurred with Dynogest was there used to be breakthrough bleeding, and that irritated the patient quite frequently. In fact, in my practice, when Dynogest came into existence, I started with 2 mg BD dose for 1 month, followed by 2 mg OD dose, and they never had any breakthrough bleeding in those cases. Elagolix versus Relugolix with add-back therapy. Efficacy of elagolix monotherapy compared to Relugolix with add-back therapy based on systemic review and meta-analysis October 25. What did they find? Elagolix monotherapy showed better efficacy compared to Relugolix combination with add-back therapy. See, Relugolix is always with add-back therapy because it contains estrogen as well as some calcium. Progesterone, sorry. Elagolix is monotherapy, dosing flexibility appropriate for the management of endometriosis, while Relugolix with add-back therapy is very good for stopping the bleeding due to fibroid. In a case of fibroid, if you come across heavy menstrual period, nothing to beat Relugolix with add-back therapy. Hence, elagolix strikes a balance between efficacy and safety. Hot flushes and night sweats 24%, headache 17%, nausea 11%, while with 200 mg you found hot flushes and night sweats were 46%, practically double, headache 20%, etc. Scar endometriosis. This was a patient who was 39-year-old with scar endometriosis on the abdominal wall. They gave elagolix 150 mg once daily for 3 months. After a 2-month follow-up discussion, the patient reported complete resolution of abdominal wall and hip symptoms. So, this is a good drug for scar endometriosis. Elagolix reduction in endometrioma size. We always wonder what happens to the endometriosis size of the chocolate cyst. And they have found good. Following initiation of therapy with elagolix, the patient reported a significant improvement in the symptoms and quality of life. On second look laparoscopy, a marked reduction in size and number of implants was observed. What happens in adenomyoma? A 41-year-old nulli-gravida woman with a history of surgically diagnosed endometriosis treated surgically at initial laparoscopy 1 year earlier and taking norethindrone acetate 5 mg per day Since then, presented for an initial visit to discuss the treatment option for presumed refractory endometriotic pain and 3.9 centimeter fundal uterine adenomyoma. She was given elagolix 150 milligram OD. Patient had no hot flushes and her only side effects in starting elagolix was mild dizziness after taking a dose which patient managed effectively by taking a medication. And what happened to the size of adenomyoma? It became 2.7 centimeter from 3.9 centimeter. So it is supposed to be quite effective for that. This is a slide showing treatment difference between elagolix and Dinoges, both given for 3 months. What did they find? Elagolix provided better pain relief, heavy menstrual blood reduction and hemoglobin improvement than Dinoges in these cases. Side effects are generally fewer in elagolix group compared to Dinoges group. Let's forget about this also. Let's come to role of elagolix in a case of infertility. Ovulation suppression. Oral elagolix offered equivalent benefit in ovulation suppression to injectable GnRH. Premature ovulation, none in either group. Gonadotrophic usage and stimulation days similar between two groups. Oocyte retrieval 30.31% versus 30.55%. Practically you will find both were same, no difference. This was a study again between elagolix versus injectable subcutaneous GnRH antagonist, a meta-analysis in IVF. 200 milligram of elagolix was given, and what did they find? Cycle cancellation rate and mean number of mature oocytes retrieved, and secondary outcome included fertilization rate and blastulation rate. Effects of oral GnRH and injectable GnRH were compared for the cycle cancellation rate, and effect of oral GnRH and injectable GnRH were comparable for the fertilization rate. So they didn't find any difference between the two. Antagonist showed comparable efficacy in following outcomes. All these outcomes, oral GnRH antagonist is a less expensive, less invasive treatment option compared to injectable GnRH antagonist, attractive alternative for fertility clinics. Suppression of ovulation in donor oocyte cycle. What did it show? Elagolix caused a slightly larger LH drop and E2 increase, but differences between groups were not statistically significant. Cycle cancellation rate, fertilization rate, blastulation rate, frozen ET, fresh ET, no significance difference. Control ovarian stimulation with elagolix in intrauterine IUI. Women treated with elagolix showed complete absence of premature luteal surge and premature luteinization, and the difference was not very significant. A dose-dependent suppression of LH, FSH and E2 were reported in premenopausal women with maximal suppression at a dose of elagolix 200 mg daily for both LH and E2 in these cases. Hence, oral elagolix offered equivalent benefit ovulation suppression to injectable GnRH. Pre-IVF in endometriosis patient. Oral GnRH antagonist elagolix in approximately doses for 2 months in women with endometriosis before eploid transfer yield highly encouraging outcomes that are equivalent to those achieved with parenteral administration of GnRH antagonist. Efficacy and safety of elagolix. Proven efficacy in all types of endometrial pain. It can be dysmenorrhea, dyspareunia, etc. Faster onset of action within first cycle. Dosing flexibility, we know that it can be 150 mg or 200 mg. long-term proven efficacy and safety, decreased use of rescue analgesic, maintained menstrual cyclicity, lesser impact on BMD and faster recovery of BMD loss. Thank you.
मुझे बोलने के लिए बोला गया है। दो सीमाएं बाजू में बैठी है, दो बाउंड्री बाजू में बैठी है, तो मेरी आवाज़ कहाँ से निकलेगी? सीमा ऑलरेडी बाजू में बैठी है, तो थैंक यू वेरी मच सर। अश्विनी उद्धार करो, आप ले लो।
Well, good morning. Excellent morning talk on 2 medical treatments. Well, the surgical guys must be feeling itchy. Anyway, still time for you guys. Medical therapy, yes, mainstay of therapy we know, but there are a lot of things which should be spoken when it comes to treating patients. As we all know, case selection becomes very vital. What to choose, when to choose, how much to choose. So Mukesh is an excellent talk. Always you have been absolutely through one into the other. Now when we selecting COCPs, which one will you select for progesterone containing? How will you use? How many months at one given time? How long can you use?
मुझे जयंती कामत मैडम ने बहुत एक ब्रह्मास्त्र दिया। मुकेश कुछ भी क्वेश्चन आएगा ना, बोलना सरावगी सर है ना। When I was studying in Cooper, I was working under both of them, and I have worked with Dr. Sarawgi sir as a resident, and madam was associate professor there, assistant honorary, assistant honorary. So madam was always the smart person, you know. Sir ko jaake pucho. Okay, on a serious note, coming back. So I have, in the modern day, I have experimented with so many different types of OC pills, but finally I have boiled down to Dynogest, and it's my favorite first go-to drug when it comes to progestins. And I would want to start either as a single progestin or in combination depending on the patient's, as I said, shared decision making. I would start off and continue non-stop, but I would call them back in 6 months to review. I would do the sonography. Now, why sonography? Because sometimes sonography may you see those, cystic glandular appearance on the endometrial lining, which in perimenopausal or post, fertility patients may be confused as suspicious abnormal lesion, which actually कुछ नहीं होता है. Histopath report में कुछ नहीं hyperplasia लिख के आता है, but दिखने में ऐसा लगता है कि there is a abnormality and it may be a pre-malignant tissue. So that is one thing. Second thing is if a woman says that I want menses in between. So sometimes I tell them, okay, if you want to take a break, you take it for a few months, depending on the patient's choice, 3 or 6 months, and then ask them to take a break. Half of them will menstruate, remaining will not. But then you have to counsel them that even if you don't menstruate, it's okay because there are a small section of patients who will not menstruate even with progesterone only pill. Now, third thing is that if the patient is very early as in a young adolescent girl with severe dysmenorrhea, then these are the patients where I would not use Dynogest. I would rather go on low dose pills. If you do, because Dynogest do not come with the low combination estrogen pill, but low estrogen dose pill are also available for these first line low dose pills. And I don't want to use the brand names. You all know about that. Sometimes I may use 24/4 combinations for these patients as a first line of treatment. So young adolescent girl, to summarize, young adolescent girl, low dose OC pills, 24/4 combination instead of 21/7. If the mother is not very convinced with OC pills, then stick with progesterone only, but then the young girl not having cycle is a bigger challenge. So to talk to them, to discuss that if you want cycle 24/4 is a better option. If it is a preconceptional, no OC pills, only progesterone only if we are awaiting the time and to start the treatment, or maybe one shot of GnRH analog to help her reach that point that the suppression is there and then we start off the stimulation. If it is post-surgery, then again, if the patient compliance is good, I would put her on long-term progestin-only pills or OC pills, depending on her choice. But my favorite go-to post-operative is to give them a GnRH analog injections because that helps the patient to have a prolonged disease-free time, and also to suppress those cells which have been missed out on surgical intervention.
Now, what I think I heard somewhere was they follow the 84-21 day break. 84 days, 4 cycles, and then 21 days take a break, then 4 cycles. The only question here we have to answer, suppose this girl is 20, 21 years old. How long can we pull on till she goes into parenthood, desire to getting married and having children? So the bottom line is, how long can we continue COCPs? Nobody can answer well. For this thing, PCOS, we've been using it for years together, so maybe we can use for a longer time. So the concept was 84-21, take a break of 21 days, start another 4 packets, 1 packet off, 4 packets, 1 packet off. Coming to Sarogi sir, Dynogest 2 years back was the golden molecule. Everybody said beautiful drug, nothing like it, it worked magic. I've used it for 7 years on a patient and she's very happy and become menopausal by now. Great. Now what I want to ask you is, where will you choose Elagolix? Where will you choose Dynogest? Because Elagolix has got a dead end. 6 months, take a break, 6 months, take a break, 6 months. After 2 years, you're back to square A, right? Now here comes the question of Dynogest, which is a long-term usage safety margin. So where does Dynogest stand today?
Manohar, you forget one thing, that in one of my slides I showed you that Dynogest and Elagolix both have equal results. In fact, you talked about 7 years. I had a patient who used to get hemothorax every month. She was admitted at Nair Hospital. Somehow or other we could diagnose that it is nothing else but endometriosis of the pleura, which bleeds every month. She was put on Dynogest. For 5 years she continued for Dynogest. She stopped Dynogest and she is symptom free now. Only advantage of Elagolix is what, you forget one thing, that Elagolix is dose dependent. If the pain is severe, you can put her straight away on 200 milligram BD for 6 months. And then gradually you can taper it to 150 milligram OD for maybe 2 years. See, study in India is only just 2 years old. Maybe you will find that these drugs can be used for a longer period also. Dynogest also, when it came in market, it was marketed only for 1 or 2 years, not more than that. We have been using it. That's a different story. So time will prove exactly what is good, what is bad for us.
Can I add one more?
Counsel for threshold bleeding, because the estrogen levels will become subnormal sometime.
See, I'll tell you, with increasing dose also, there are 50% chances that they'll get period. So you,
If the dose is increased,
uh-huh.
if the dose is increased to 200, and we know that lowering of estrogen is going to cause, threshold bleeding. We know of that, and should we counsel her and
See,
take care of
remember
it?
one thing, whenever you're starting with 200 milligram dose, you have to counsel the patient for many things. One of them is, yes, threshold bleeding can occur. Second thing is about BMD. She has to be aware that she can get a fracture anytime. Third thing, that you cannot give this drug for 200 milligram BD for more than 6 months. Then probably you can taper the dose and decide accordingly. So these 3 things have to be kept in mind.
So I have a question. You talked about EB2 receptors. So the tissue is whatever we remove. Suppose she has a ovarian endometrioma. So that tissue has to be sent for EB2.
Yeah, that tissue has to be sent.
And what is the cutoff value? And
I don't know much. These are all latest things which have
Okay.
come in market. They are very latest. Yeah. I really don't know about it, but I was just going through it and I came across this, that they are sending the tissue. Probably you will be in a better position to tell us. Sending the tissue for receptor status. No. This is the latest thing which has just come in market.
Okay.
Not yet, but it may come into future. Quickly about, sir made a very brilliant point about Dynogest versus a GnRH antagonist. I would like to point out here. So there have been enough studies where, at this time, till the long-term data for antagonist comes, we have to understand that we are using an antagonist instead of agonist right now. Injectable ki jagah pe oral. So it is not a replacement of first line, it is a replacement of second line. Second point here is that there have been long-term studies, in fact I can quote it but for the paucity of time, where the antagonist has been used followed by Dynogest. It was found that initial response is better with the GnRH agonist, but long-term outcome of agonist starting and continuing with the Dynogest is actually as good as a long-term outcome of Dynogest alone. So if you want an immediate quick relief for severe pain, then an antagonist or agonist to start off with, and long-term maintenance by this till the data comes. As sir rightly said, that we are awaiting data, because when it came for 6 months, 2 years, now 8 years, 9 years we have for Dynogest. Similarly for antagonists also we'll get the data. Till that time, as clinicians with evidence-based support, we can start off with this. One more keyword about the dosage of antagonist. The SOGC guideline says that up to 150 you can start it empirically, but not at 200 BD dose. For that you need to have a laparoscopic diagnosis only. So that is because, as sir pointed out in one of the slides, that non-endometriotic pain relief was also found with the GnRH antagonist. So we have to balance it. So to summarize again, long-term, right now, with existing data, Dynogest. Short-term, immediate, for profound pain or resistant cases, go for antagonist or agonist.
We are running short of time, so let's felicitate our speakers and chairperson and move for the next surgical session.
I request Dr. Anurag Bhattesar and Jayanti Kamath madam and our chairpersons to felicitate our speakers. Dr. Sarogi sir. Dr. Mukesh Gupta sir. I request both of them to felicitate our chairpersons, Dr. Seema Rai madam, Dr. Seema Gadevan madam, and Dr. S. N. Agrawal sir. Thank you so much everyone. So this session, last session taught us what to be given, when to be given, whom to call for surgery. So from whom to call for surgery to how to operate. Let's move ahead with the second session, the surgical session. I like to call upon our chairpersons, Dr. Kiran Shinde sir. Sir is a medical director of Ashirwad Nursing Home, Anand Nagar, Dahisar. Also honorary of Bhagwati Hospital and BDBA Hospital, Head Unit. Welcome, sir. And Dr. Raju Sahitya, sir. He is a medical director of Pushpa Hospital, also attached at Hinduja Hospital and Cloud9. Past president of ISPAT, past president of AFG, and executive counseling member of past 12 years, MOGS. Welcome, sir. And Dr. Motwani, sir, the universal savior of us. Thank you, sir, for accepting. Over to you, sir. Please call the next speaker, Dr.
Hello.
Vivek Salunke, sir.
So today being a very auspicious day, like of the 3.5 auspicious Muhurats, today is Akshaya Tritiya. The other days being Dasera, Gudi Padwa and Diwali Padwa. So a good day to start the sessions. I think after understanding the etiology of endometriosis, studying the medical management, I think we should dwell now into the deep infiltrating endometriosis. And we can't have a better speaker than Dr. Vivek Salunke.
Program on endometriosis, as we now practice, clinical practice, we are day by day seeing more complex cases, more cases which I have previously operated, and due to increase in awareness, we have to basically focus on how to diagnose them early and offer them the early treatment and diagnose the multi-organ involvement. So I would be speaking on safe surgical decision making in bowel endometriosis. So is it common to have bowel endometriosis, endometriosis involvement in bowel? So it is not very uncommon. Around 5 to 10% of endometriosis patient may have bowel endometriosis if they are investigated and assessed properly. So the focus of this talk today would be how to recognize, investigate, counseling, plan the surgical path, and know when to have a referral for this patient to the centers which are tackling these cases safely. So if you see the involvement in the bowel, most commonly involved part of the bowel endometriosis is rectum and the sigmoid colon, and another would be cecum, appendix, and cecum and the appendix areas. So if you understand the endometriosis invading the nearby organs, this is a uterus, this is a back part, the posterior wall of the uterus, the torus area and the vaginal area. So the back wall adenomyosis can penetrate into the upper rectum, the torus area you can go in the middle rectum, and the lower part, which is the most critical and problematic disease, the vaginal nodules can go into the lower part of the rectum where your inferior hypogastric plexus are situated, and more tricky areas to operate because it is associated with the endometriosis of a deeper parameter. Again, if you see the adnexal involvement can go and penetrate into the ileocecal lesion on the right side and the sigmoid stenotic nodules on the left side. It's important to know how our patients present. They can present with the pelvic pain, dyspareunia, dyschezia. We can always chart it in the VAS score system. Loose stool during periods. You can always ask your patients if they are having altered movements of bowel during periods. Does the bowel passing movements change during periods? Whenever there is superficial infiltration of the muscularis, we have increased frequency of motions, and they say my motions ease out during periods. So you should always suspect bowel endometriosis in such cases. Dysmenorrhea, radiating pain to the legs, because whenever there is a uterosacral involvement, you can have pull on the sacral nerve roots, not actually involvement of the sacral nerve roots, but the pull on the sacral nerve roots and the sciatic nerve areas. Bowel symptoms during menstrual cycles commonly are misinterpreted. They may be diagnosed as irritable bowel syndrome. So what are the red flags to watch all in our general practice? Cyclical rectal pain, painful defecation before, during or after menses, posterior compartment tenderness on examination, the nodularity and tenderness. Whenever patient has prior endometriosis surgery, when this is a recurrent endometriosis, and when you suspect a multifocal deep disease. So how to diagnose? First is most important, two most important imaging factors, transvaginal sonography and MRI. So as clinicians, we should understand the endometriosis and how to do sonographies to diagnose endometriosis of bowel or the deep endometriosis and read the MRIs. So if you see this particular video, you can see a nodule which is going in the muscularis layer. This is serosal involvement, this is a muscular involvement, and when there is this is a submucosal involvement. You can see this in a longitudinal section, a large nodule, this is a hypoechoic muscularis, serosa hyperechoic, and again you can see a large nodule which is coming, and when you see a transverse section, you can see the circumference. This is a sonography picture of the, when you see, you identify the bowel as, this is the posterior wall of the bowel, this is the anterior wall of the bowel, and when you see, this is a large nodule in the involvement of the bowel. When you learn to look behind the uterus, put your probe in the posterior fornix and trace the bowel from lower part of the cervix to the torus and above that till the area of upper rectum, you can identify a nodule in the bowel if you keep on tracing from down. So this is a large occlusive nodule. You can see a thickness. Coming to the MRI, in MRI T2 weighted images, you can see the endometriotic lesions as T2 hypointense area. You can see this particular area. This is a uterus. This is a torus area. You can see a hypoechoic nodule which is going and coming to the superficial muscularis part of the rectum. So this is involving this is again a posterior wall disease going into the superficial layers of the rectum. This is a large vaginal nodule which you can see involving the lower rectum. And again, this is a mushroom cap sign. This is a big nodule. If you trace the bowel from here, you can see a large nodule which is occlusive nodule. The thickness here would be around 1.5 centimeters, and the involvement could be probably more than 40%. So what information we want from the imaging is the extent of the lesion, the depth of the muscularis involvement, invasion of the muscularis, the circumference involved, the number of lesions and the distance from the anal verge. All these things will help you to make your surgical decision about the surgery and counsel the patient that you are going to require one of the three surgeries like shaving, a disc or a segment resection. So surgery is indicated when there is a significant pain, organ dysfunction, bowel occlusion, failed medical treatment, and when patient is deep endometriosis, bowel involvement, going for IVF cycles. And it is important to counsel the patients regarding their symptoms, give them statistical information about their post-operative outcomes of the functional outcomes of the surgery. You discuss the type of surgery which they may undergo and intra-op change into the in the type of surgery if it is required, and the functional outcome to the if there is a very ultra low resection, we will talk to them about low resection syndromes, the increased frequency of motions, constipation rates, all the things have to be discussed prior. So it has to be managed in a center with a multidisciplinary team with a colorectal surgeon when bowel endometriosis. Coming to the surgery, there are three types of surgery. There are two basically approaches for bowel endometriosis, a conservative approach and a radical approach. In conservative approach, we have two surgeries, the shaving and the disc excision, and in a radical approach, we have a colorectal resection or a segmental bowel resection. So whenever there is a thickness of 7 millimeter plus and a long length maybe or a multiple involvement, they may go for, and the circumference involved around 30%. The surgery required may be a colorectal resection, and most of the other cases can be managed with shaving or a disc excision. So coming to the conservative surgeries, there can be superficial shaving, that is the excision of the superficial nodule, deep shaving till the mucosa, superficial shaving can be till the muscle layers, and when there is a full thickness excision, it is a disc excision. It can be done by without a stapler or with a stapler. Coming to the surgery of shaving, excision of nodule without opening the rectal lumen can be done by monopolar energies, harmonic scalpel or scissors. Aim is to complete removal of nodule with bowel conservation. It has low rate of complication, low rate of functional outcomes changes, and could be offered as a first line when it is feasible. If the problem with shaving is it can differ according to the surgeon's understanding. So to understand that the shaving as far as possible should be the complete and yeah. नहीं हो रहा है क्या? चलो कर्सर नहीं दिख रहा है, वीडियो नहीं चल रहा क्या? Okay. चलो. Okay, so this is a case where we are describing shaving after the adhesiolysis. After the nodule is isolated from the vital structures, you start digging, you start shaving in the from the, you first thing is the fat around the nodule is removed and the nodule is isolated, and then we start your shaving at the cranial end, and you can see the endometriotic thick tissue and the supple muscularis layer. So it is important to isolate it from the surrounding fat so that you know the margins and you can do the shaving completely. You can see the complete removal of the disease from the muscularis, and whenever there is less circumference involved, you can reinforce this area with sutures. We generally use barb sutures 30 or 20. The testing of the bowel has to be done with methylene blue or gas. This is the bowel testing done. Yeah. Coming to the full thickness involvement, that is the surgery required is disc excision. It is full thickness excision of the diseased portion of the bowel wall. The resultant defect can be sutured or stapled. End-to-end anastomosis stapler passed from per rectal can be used for this purpose. So the lesion has to be less in length, around 3 to 4 centimeters, and depth, and the circumference should be less. So again, the advantage is there is no bowel denervation, no length or volume loss in the reduction, and no functional. The functional outcomes are better. So if you understand, if you put an end-to-end anastomosis stapler per rectum, you isolate the nodule, take a stitch on the lower and the upper part, and invaginate the nodule inside the end-to-end anastomosis stapler and excise only this part. It comes out like a patch. So this is a case where there is a bowel involvement after the adhesiolysis. These are the various steps of surgeries which I will not go into detail. Once you isolate any bowel endometriosis surgery, first thing is isolation of the disease, and then the surgical planning of whether shaving, disc or segmental resection. So this is the releasing of the rectum from the torus, and then isolating it from the nearby structures. This is the excision of the disease. So once we isolate it, then we start removing the surrounding fat. Take a stitch on the upper and the lower border. This is an end-to-end anastomosis stapler which goes in the rectum. You stop it at the lower margin and open up the stapler. And then the laparoscopic will tie the knot and put your hand down and antivert the stapler so that you only the only anterior wall is getting excised, which has the disease. The advantage here is we don't open up the bowel, and you can see a disease getting excised in the anterior wall. Yeah. So this is complete removal of the disease when it is full thickness. Thank you. And again checking the bowel. So at times we can do it without actually using the stapler by preparing the bowel well and opening the lumen of the bowel. And under vision excising it. And suturing it in 2 layers. Very important thing is we have to have a circumference which is less in this, because if you have a circumference less, and then if it's possible you to suture it transversely. If the circumference is more, you may suture it transversely, but if it's a very less circumference, 10 to 15%, you can actually suture it vertically also. Coming to the third radical treatment of endometriosis, colorectal segmental resection. It's a radical management. Many times I hear surgeons say we don't do colorectal resections in our practice at all. See, there has been a big study by Donis that colorectal with most of the cases of bowel endometriosis, around 85% of cases can be well managed with shaving or a disc. But there are percentage of cases which require a resection. A patient requiring a resection, you do a shaving is not a complete treatment, you will not get a symptom relief. So to identify such cases and offering them the same treatment gives them a more safer treatment than doing the shaving or a disc. So it's a radical management, removal of small bowel segment. It is the most commonly used in colorectal surgeries and a standardized procedure for a long involvement in length and thickness, plus more circumference involving more than 30 to 40% and multifocal lesions, you require colorectal resections. The advantages is more standardized, less recurrence. The chances of leaks, we tell our patients, around 2 to 3%, they are not more. And only thing which is peculiar to colorectal segment disadvantages is the chances of stenosis, which is only peculiar to colorectal resections. It doesn't happen in shaving or a disc. And the chances of low anterior resection syndrome, when the resection area is low, maybe they will have frequent stools, incontinence, all these issues may take time to settle. So the lesions like this, quite a thick wall lesions, and multiple lesions, it's required that they undergo a colorectal resection. So I will not go into a lot of videos, but this is a colorectal resection where we are nowadays using a single stapler technique, where we just use a one circular stapler and complete the procedure. So in this is a large involvement of bowel. You have isolated the bowel nodule, which is a stenotic bowel nodule. Then we start dissecting very close to the lower margin. In this, advantage is the rectal branches, the superior branches to the lower segment, the vascularity is maintained. We don't have to take the bowel out. Initially, we used to take the bowel out to put the anvil inside. So we dissect very close to the bowel, isolate, and at the lower margin, this is the margin, lower margin, open up the bowel. We have to prepare the bowel very well with this. We put them on low residue diet for 2 days and give them mechanical bowel wash. This is a large nodule, and then from the upper and the lower part we can detach it, take the specimen out through rectum itself. And then put the anvil inside, take a purse string, suture, Then this is a lower margin. You take a one more bursting suture down. And do the anastomosis. So patient has no big scars. It's done in 110 mm and all 5 mm. No mini laparotomy. So this is a paper. We have to be conservative on bowel. What basically around 95% of deep endometriosis patients are feasible for shaving, and it exposes to low rates of complications. Shaving and rectal resections are comparable in terms of recurrence rates. So first option we should keep is rectal shaving or a disc excision rather than doing a colorectal resections. Again, the post-operative complications, if you compare, they are more in the segmental resection group than the discoid and the shaving group. Similarly in this paper also. So complications what can happen with this bowel surgeries is rectovaginal fistula, more in segmental resection, anastomotic leaks, hemorrhages, infection and pelvic abscesses. So to end my talk, to suspect a disease early, map counseling, do good counseling, refer the complex bowel cases, tailor the surgery as per the need of the patient. A multidisciplinary team approach is very important, and we are in your unit doing these cases in 3D vision only. Thank you.
Very well presented. So it's not about just pain, it's about the organ dysfunction, what we are talking about. And operating on bowel endometriosis is like being in war zone. We have to find the bunkers and the mines where they are buried and identify and be as conservative as possible.
Yes,
That's the message you gave. And questions, we want to leave it for after both the talks. Yeah, so I will request Dr. Dr. Manohar to please introduce the next.
Another excellent surgeon. We have two veterans today. It's such a pleasure to have both of you here. Both come from a war zone. Both really are excellent surgeons of endometriosis, among the top in the country. I would put them that way. Not exaggerating one bit because I've seen them operate. They are phenomenal. Now, this gentleman we have for the second talk is a pelvic endoscopic surgeon, exclusively practicing pelvic endoscopies from 2001. So that's a good 25 years experience there. His surgical kingdom is not limited to India. His surgical kingdom expands to Kuwait. Hemant, I hope you're hearing me. Kuwait, Abu Dhabi, well, still a war zone there, so I don't know whether he visits now. And of course, the Indian kingdom is from Saifi, Breach Candy, and also R.N. Cooper Hospital and whatnot. Well, we've seen this man at work. He's got some, he always posts some good videos on YouTube, short little videos with a lot of, knowing the anatomy, how to go about it. Because all this game of endometriosis is you should have excellent anatomy. If your anatomical knowledge is pathetic, you are in doldrums, right? So Hemant, on to you to listen to you. We are waiting. Let's see. What are you going to discuss about unraveling the mysteries of ureteric endometriosis? A gynecologist's care is always the urinary tract. So on to you, Hemant. Thank you so much, sir, for those kind words. Am I audible? Very much.